May I now request Dr. Rajendra Prasad to please come and address us on the clinical pulse in respiratory allergy. I don't think anybody really needs to, listen about him. He is a very well-known figure, a stalwart in pulmonary medicine who's probably taught each and every pulmonologist of the country at some stage or the other, whether in classrooms or in lecture theatre halls or in the conferences. We've all always learned from him and always looked upon him. He's the Director Medical Education, Professor Respiratory Medicine at ERA's Lucknow Medical College and Hospital, Vice Chair of the National Task Force India, and Emeritus Professor, National Academy of Medicine, Medical Sciences, Emeritus Professor for Indian Medical Association and Convener of the State Chapter for the National Academy of Medical Sciences for UP. Sir.
My slides are coming. Thank you, Nagia, for very, I must say, elaborate introduction. This was an interesting case. So, this is the last lecture. I think you people are also tired, and including me. So, I'll try to be very brief. And I usually nowadays start my lecture with some of the sayings, and I'll start my lecture with this, that better than 1,000 days of diligent study is one day with great teacher. I'm not saying that I am a great teacher. Since Dr. Ansari is sitting here, who has been my senior during my PG days, so I'm saying this for my mentor, Professor B.K. Khanna. And there are many more. At least we are three sitting in this audience I can know who has been mentored by Professor B.K. Khanna, Ansari ji, and myself and Dr. Katuria. Very hard taskmaster. And these are my institutes. I'll not skip. So when Pathak asked me to speak something about interesting cases in respiratory allergy, I was very busy those days. Then I searched some of the cases which I treated in my lifetime, and I'm going to share with this. This is a very young old boy, student who was studying in a convent school, came with complaints of excessive sneezing since 2 months. His father gave history of sudden bouts of sneezing and mostly during day, but no sneezing in the night after patient sleeps. During day he has all 12 hours sneezing. So they had visited various doctors, and the teacher I referred that he has a foreign body in his, the same teacher referred this young guy to me for allergy testing. That why he is sneezing for last so many years. So he also visited ENT surgeons, all investigated, and nothing was found. So ultimately referred to me for allergy testing actually. Then I did examine, took history in detail. I could not find anything anywhere, either in the nose or in the chest. And X-ray picture, CT-PNS, spirometry, I did normal limits. So what he was given symptoms, what to test that really is allergic or not. So I gave broadest spectrum anti-allergic, whatever is possible, including steroids, for about 7 to 10 days to test, because my initial impression was he is not having, he is creating this for something. So, but after 8 days he came in my clinic again, and I just heard that he is sneezing. So he was observed during OPD follow-up that the child was not sneezing when he was engaged in some activity. As I said, he was a convent. He was studying in a convent school, about 7th standard. So I asked him, मैंने कहा भाई तुम ऐसा कर, 1 से 20 तक गिनती, तो हिंदी जरा कम आती है अंग्रेजी स्कूल वालों को। हमने कहा हिंदी में गिन और 20 से शुरू कर और 1 तक आ, रिवर्स आर्डर में। तो उसने 20 से लेके 15 तक तो गिन दिया। 15-16 के बाद जब देखा कि उसका दिमाग लग गया वहाँ सोचने में कि 15 के बाद क्या आएगा, तो ही स्टॉप्ड स्नीजिंग एंड हिज फादर वाज अ हार्ट पेशेंट। और फादर क्या कहता था, मैं आपको स्टेटमेंट सुनाऊं, वो कहता था डॉक्टर साहब इसकी एक छींक मेरे दिल पर जा रही है मेरे दिल पे जा रही, तो साहब इसको आप कुछ करो, व्हाट इज दिस। आपके गुरु भी ना समझ पाए। मैंने कहा भाई, देन while counting he stopped sneezing in front of me, in front of his father was standing beside him। मेरा मन तो यही कर रहा था इसको एक लपड़ तेज मारे लेकिन मैं हिम्मत नहीं कर पा रहा था। लेकिन टू योर सरप्राइज his father, because father was also very educated, so he understood that he is imitating, he is doing malingering, so he slapped a lot a very big slap he gave, and वहीं उसकी छींक बंद हो गई और फिर हमने उसको पूछते रहते थे, भाई कभी आई दोबारा? बोले साहब कभी नहीं आई So what I am trying to say, sometime in clinical practice, we do such type of, I hope in every clinical practice, we see such type of patient. Then another patient, he was about 22-year-old male, again complaints of breathlessness, presented as asthma. But he had streaking also. Somebody wrote him anti-TB drug also. I don't know with this X-ray. I was talking regarding the X-ray. However, we find that there are, if there are laser pointer. So with these shadows, some doctor has prescribed anti-TB drug. That's very common in this state. Without and then when he received 6 months of all 4 followed by 3 drugs, you see lesion has drastically increased. If these 2 X-rays are shown to even me without anything in history, I would also say it is MDR-TB. So he was diagnosed as, he was suspected as MDR-TB because you can compare these 2 X-rays, and so he was referred to me. Rather, doctor wrote treatment for MDR-TB in those days. But he was very smart. उन्होंने कहा एक बार यार डॉक्टर साहब से पूछो कि MDR की टीबी की दवाई खाएं कि नहीं खाएं. Then what I did, when it came, I took history, since there was history of asthma-like presentation. So first thing I did was sputum examination. It was negative. With such an extensive lesion, if sputum is negative, it is telling something. Mantoux test was 13. हम कहते हैं ना IGRA, Mantoux, gold, platinum, there were so many things. They are nothing. They just tell you that person is infected. तो उसका कोई मतलब नहीं था. In TLC, if you see the pointer was eosinophil was high. So that prompted me to investigate him further. And in further investigation, we did skin tests. It was positive to Aspergillus antigen, even type 1. In those days, we used to type 3 reaction also. And then CT picture are very typical of a central bronchiectasis in those days, we used to say. And you know, this picture was very typical of central bronchiectasis. And finally, even total IG against Aspergillus fungus and IgG, all were positive. This was a classical presentation. If you see, it was diagnosed as allergic bronchopulmonary. So this is not very uncommon disease, you know. In our day-to-day clinical practice, we see lot of cases. And you see that what 6 months of ATT could not do it, a course of steroid, because treatment of ABP is essentially steroid, oral steroids. And so had made all difference in about 6 weeks of time. So that is another case. I'll just quickly scan through. He was again 20-year male. He came to me in 80s. He's alive and following him up. So about 45 years. So he has breathlessness for 10 years when he presented to me along with little hemoptysis. And you see the X-ray picture. Looked like consolidation, disappearing after about 6 weeks. That it has changed its place. Now it has come into left upper zone, left middle zone, right middle zone. You see all these shadows are fleeting. And this is one of the typical, now it has moved to the left lower zone. And so I just said it was probably pneumonia is walking in every, and this was ultimately diagnosed as, this is the one patient who taught me ABPA, because I am seeing this patient from 1977 onwards. So about 50 years hone wala hai ab. But luckily he is alive, so it's not very fatal disease, provided you manage them well. And it was, all the investigations were positive for ABP, although those days these IGs, specific IG, they were not very common to find out, but on a research protocol we managed to done. And these days we used to do bronchography. So this was central bronchiectasis, very typical picture of central bronchiectasis is visible. And we catch hold of him in 2007. Even CT those days was not available in KGMC. So in 2007, we catch hold of him and we got CT thorax done, and typical central bronchiectasis picture were available. So they are all diagnostic criteria. If you read that diagnostic, and these are the few other pictures of ABP. I'll just mucus plugging there, what you call now a mucus ABPA MP. And then sometimes it's present like a mass-like structure. Again, this was a case of an ABPA, central bronchiectasis we see, and last case I think I'll go. अभी investigation की कोई बात कर रहा था. I saw this man about a month back. You see the CT picture, typical of ABPA. CT picture was typical of mucus plugging, but the investigation has shown otherwise. They have not shown, in the first say, it says that IG was raised, but specific IG and were not raised, and further on next investigation from next lab. So even labs vary in there, or what I'm trying to say. So you have to be very careful. And it was diagnosed as ABPA ham, and this lady presented with collapse. तो collapse में लोगों ने फिर कहा ये TB हो गई इसको. Young lady, teacher थी, तो मैंने कहा उससे पूछा, हिस्ट्री डिटेल में पूछा, तो हिस्ट्री में पता लगा कि पहले उसका अस्थमा का हो चुका है, उसका एक पुरानी जो है यूसनोफिल काउंट था 15% का. That prompted me to think, and again this collapse was because of mucus plugging, and it was diagnosed as case of ABPA. So what I'm trying to say that ABPA, it's not very rare disease. Even we did a study and we could find in the state of Uttar Pradesh, it is around tune of about 7% in one of our study when we have screened about 244 asthma patients. And these are the diagnostic criteria which is available in any book now, and all the criteria in most of the cases has met, and ISAM criteria has come recently, even modified ISAM has come currently. So what I'm trying to give, and there were many types of ABPA now described, latest guideline available in ERJ 24 by Chandigarh group. They have defined ABPA, many types of ABPA, B, MP means mucus plugging, HAM, high attenuated mucus, and CRF, other findings were there. So this is all. So my take home message with these interesting cases which were mimicking like allergic patients is that every patient today what this 24 guideline, and we are also practicing that every patient of asthma must be screened for Aspergillus sensitization first, that you can do by doing specific IG, against Aspergillus fumigators, or by doing skin test. This is possible now everywhere. And if you find this, then try to find out ABPA also. By ABPA, you have to do specific IgE against Aspergillus, and then CT pictures are very, very typical. So what I say finally, that when I teach that any patient with bronchial asthma should undergo a skin test or this, and final message is, asthma, if I teach like this, if any asthma patient, you have some pulmonary shadow, and simply TLC, DLC may show eosinophil count between 10%, more than 10%, you must suspect this condition. These things are little bit changing. In eosinophil is more than 500 is taken as IgEs also level has reduced. So only take home message with this presentation, that any asthma patient had some shadow or chronic asthma patient, always try to think about this condition. First the sensitization will occur and then ABPA will happen. With this, thank you very much. We have many books and many things. I do have to go. And thank you very much. If you have any question, I love to answer. मैं पाठक के सारे दो लाइन बोलना चाहता था। पाठक जब पढ़ते थे तो इतने मोटे नहीं थे। अभी ये बहुत इन्होंने वेट गेन कर लिया। I will suggest him, and I must appreciate Dr. Pathak that he asked me in 2014 when he started this कि सर क्या करूं कि ना। हमने कहा जरूर करो. This is the area. In those days the pulmonary medicine was not very, अभी भी बहुत अच्छा नहीं है मैं तो कहूँगा, but please do it. So I am very happy that he is regularly doing it, and probably I have come in every conference. So thank you, Dr. Pathak, for remembering me, and thank you very much.
Thank you, sir. Now I would request Dr. H.S. Ansari, sir, to present Memento and Angavastram to Dr. Rajendra Prasad, sir. I would request Dr. S.K. Pathak, sir, to present Angavastram and Memento to our chairperson.